see how well your systemic therapies are working over time.
Okay.
Which is going to be kind of ultimately the determinant of that. Because you are right to say that I would say that each individual part of your body kind of has a limit to how much radiotherapy it likes to see. That as we push that dose higher, which we can do in some circumstances, we just start to run a higher risk of a side effect to that area.
Got it.
And so it's not an absolute number where we say there's one magic number and we can't go any higher, but it's like as we start to repeat radiotherapy, the risk of causing you a problem can go from super low to starting to climb higher than we like, and we want to make sure that the benefits exceed the risks for any one of these treatments.
Yeah.
And so then it starts to get more difficult to get them in. And then our question becomes, how important is that going to be? How much bone pain will you have in the future? Well, it probably depends in large part on how well different systemic therapies are working and how your cancer is progressing. And if we have a systemic therapy that's really successful, then hopefully you don't need anything from the targeted treatment point of view and you'll have good control over it. If we start to get to the point where we're seeing progression in a bunch of spots, a bunch of bony sites through systemic therapy, we may very well be limited in how much radiotherapy we can get in. I think the places that we're talking about, which I'll talk a little bit more about in a minute, are retreatment, but are feasible retreatment.
Okay.
And so that's why I'm looking and saying, I think we can do this. We're going to have to use fancy techniques, so I think we can do it.
Okay.
And maybe let's talk about this process for a minute. So we'll do an SBRT sim, so that's when we use that larger body fix.
Yep.
And we'll put your arms up, so now they're out of the way of where our beams are coming in.
Okay.
And we'll scan you, and maybe we're able to use some of your old marks too, because they're good enough. And then make probably two fancy plans, one up at that T-spine area, and one down at that sacrum. And probably, I'm anticipating probably 5 treatments to each site.
Okay.
Do them together.
Okay.
What are you going to notice? Fatigue is common regardless of the site.
Sure.
Up here, I think what we're going to have to think about is that right in front of this vertebral body sits the esophagus.
Yep.
And that's the thing where you're probably going to notice some swallowing irritation.
Okay.
And it's not that high up, so it's like food's going to go down fine, and then start to kind of stick.
So feel like heartburn, kind of?
Yeah, and have you had that before?
Yeah, I had the magic mouthwash, which is disgusting. But I found that ibuprofen was effective as well, so.
Good. And, I find that magic mouthwash stuff does a good job numbing up here.
Right.
But it has a hard time getting all the way down and still working.
Yeah.
Because it gets more dilute. I suspect it will be modest, if much benefit by the time it's getting down to here. And so, pain medicine, which hopefully ibuprofen will be good enough, and your esophageal dose there won't be huge, but it'll be some. So that's one thing I think we may notice, and we'll be careful about doses to other structures. So I think that's the big thing you're gonna notice. I doubt you'll notice any tanning.
Okay.
The chance of pneumonitis, so irritation to your lungs from this treatment, should be quite low.
Okay.
0. Chance of having a fracture in a vertebral body from tumor, tumor plus radiotherapy, probably low, but not 0.
Okay.
Chance of injury to the spinal cord or nerves there, I think that's going to be low for us. That's why we're going to use this fancy technique. It's probably never quite 0, but I think it's going to be quite low. And
is SBRT, is that like, I've heard CyberKnife is the brand name, but is that similar?
Yeah, I think that's fair. CyberKnife can deliver targeted treatments coming from lots of angles.
Okay.
And one can deliver what we call SBRT, so focused doses that are really conformal. One can deliver that with that machine as well as with other machines, and we tend to use a linear accelerator. But yeah, that's the same kind of idea, that you can be really conformal with high doses by coming from lots of angles.
Got it.
And that's kind of what we do in SBRT. And then when we come down here, I think what's our irritation going to be? We're closer to the skin down here, so we might get a little bit of skin tanning where we're retreating. bone or muscle soreness. We're a little close to sigmoid rectum, so could you get a little bit of irritation with bowel movements? Maybe, but not much. There won't be a lot of bowel in that region. So I think here what I would be careful with is some of those nerve roots, probably get a little sun tanning back here. Long-term risks to the bone or muscle in that area are going to be small, but not zero, since we are going to be overlapping with prior radiotherapy.
Okay.
So overall, I think you're going to get through this well. I think that the expected toxicities are fatigue, probably some swallowing irritation up here and a little skin tanning down there, and then long-term risks of something untoward happening are quite small, but not zero, and again, we'll use some fancy techniques to avoid it. Is it going to work on pain? Probably, because we've had really good success.
I've done really good. Radiation is my favorite.
For fixing pain, and so I think we're going to fix those spots.
Okay.
And then it's just a question really of like, where are we at with systemic therapies and how well are those working to hold us in the long term?
Okay.
And what I had told I can't remember who reached out from your...
Tara.
Yeah, exactly. She said, can you zap this? And I said, depends where things are, but let me evaluate and then let's see how things line up. And we're kind of in spots where we've given some treatment, but not tons.
Okay.
And as long as that continues, we may yet have more to offer in the future if you need us. It's just we may at some point hit a line of adding a little too much risk.
Yep. Fair. I think I had one more question, but I lost it. Yeah, I think I'm good.
Okay. Any other...
Oh, I remembered.
Yeah.
So, I have had, I started a new chemo 2 weeks ago. I'd only received one treatment, and then my neutrophil, my IANC count became really low.
Yep.
So what does this look like as far as scheduling in tandem with chemo? Is that okay?
I would do it not at the same time as chemo.
Okay.
What I'm flexible about is, do they have a plan to give you some chemo for a little while and then we come in?
So I'm going to receive a chemo treatment tomorrow. Well, the plan is I'll do my labs first, of course, and then I'll receive the treatment on the 23rd. And then the following week, if I receive treatment on the 23rd, the following week will be my off week.
Okay.
So that might work.
Yeah, and what I might do is ask them to, hold off one extra week so we can get this in. We use the treatment we usually do every other day, and so that kind of thing. If your medical oncologist were to say, like, maybe it'll be like, hey, this works out great because you have a little extra recovery of your marrow or something. If they say, ooh, we'd really rather wait on radiotherapy and get a couple extra cycles, and that's okay with me.
Okay.
As long as your pain is managed well enough that we can take that time.
Okay.
And so I think just coordinating how that'll work out, and maybe it'll be nice for you to have a little extra time to let your counts bounce back a little bit. I think with the small volume that we're encompassing, I don't think we're gonna affect your counts much.
Okay. Good.
So I think we should be okay on that front.
Okay, and you'll communicate with
Yep.
Tara's office. Okay,
yep, absolutely.
Cool. Awesome.
Okay.
That's it.
All right. Well, before you go, I want to go through our paperwork and I want to schedule our fancy SBRT planning scan.
Okay.
And then we can get to work making a plan, and then we can figure out exactly when we want to, give it relative to chemo.
Okay.
But that's the choice. But I do think we can help in those two spots. That works
excellent.
Well.
Good. Okay.
All right. Any other questions?
No, that's all I got.
Okay. Good. Well, stay here.
Okay.
Nurse will be in. We'll get that going, and I'll talk to Tara and medical oncology and figure that out.
Perfect. Okay. Sounds great.
Excellent.
Thank you so much.
You are welcome.